start today just with an overview of the robotic system for people who may be less familiar with it. And so it basically consists of two components. There's a bedside robotic arm on top of which you set a sterile cassette, and into that the technician or bedside operator is going to load the interventional devices. And then there's an interventional workstation that consists of the robotic controls as well as a large flat screen monitor. And it's important to think about when you're considering robotic PCI, both the current and future applications of robotics. And so the first generation robotic system was cleared for clinical use in the U.S. in 2012. The current CorePath GRX became available in 2016, and it's been used for both simple and complex PCIs, and over 7,000 robotic PCIs have been performed worldwide to date. It's also cleared for use in peripheral interventions with a focus really on below-the-knee work. It has now received CE mark for some neuro interventions, and currently in development are both further developments in the neurospace as well as the ability to do remote interventions, and that's something that we'll talk about a little bit later. So this is a schematic just showing what the robotic cassette looks like. And so you use a sterile cassette for each case. You set this on top of the robotic arm. And you can see the dotted line here represents the location of your interventional wire. And on the bottom, you can see there's an RX device track. So this is where your rapid exchange, either balloon or stent catheter goes. And then there's an auxiliary track that you can place additional wires for use in bifurcation lesions. And then the controls are relatively simple to use. There's a green joystick on the right that allows you to control your guide catheter. So this is for both advancing, retracting, and torquing the guide catheter. There's a joystick in the middle that allows you to control your wire. So again, advance, retract, and torque. And then there's a controller on the left that allows you to advance and retract your either balloon or stent catheter. And then there are a series of touchscreen buttons that really allow you to maximize the precision of your movement. So using these touchscreen buttons, you can move any of your devices by 1 millimeter increments, and it's a really useful tool to have, again, to increase precision. And so what are the physician benefits of robotic PCI? And I think it really, for the physician, comes down to minimizing the occupational risks that we all face in the Cath Lab. And I think, as everybody in the audience probably recognizes, these risks really stem from radiation exposure as well as wearing lead chronically. And to optimally reduce the occupational risk in the Cath labs, we really need to address both of these issues. And when it comes to wearing lead, we know that about half of interventional cardiologists will report having some form of orthopedic injury during their career. Many of these tend to be spinal injuries. Work-related pain is extremely common in our profession. Just under 50% of physicians in the Cath lab having some work-related pain related, again, to wearing chronic lead. And one of the beautiful things about robotic PCI is you don't need lead to do these procedures. You can sit in the safety of the cockpit without lead, and I often say you don't know what you're missing until you're doing your procedures without wearing lead. So the other occupational risks, as we mentioned before, really relate to radiation exposure. And so there's an increased incidence, or maybe an increased incidence, of carotid disease amongst interventionalists. There's about a threefold risk of cataracts that we face compared to people who are not exposed. And then there's some concern that we may be at an increased risk of left-sided brain malignancies, all of which are concerning. I found this study, actually published by El Sayed in 2017, to be quite provocative with respect to radiation risks that we all face. What they did in this study is they actually measured two markers that serve as markers of radiation-induced DNA damage. And so these are biomarkers that can indicate that. And they drew blood samples on vascular surgeons both before and after the procedures that they were doing. And when they looked at vascular surgeons doing open AAA repair, as shown by the brown boxes, they saw no increase in these DNA damage biomarkers before and after the procedure. But interestingly, after a single endovascular AAA procedure, where of course fluoroscopy is used, in these physicians, they were able to measure a rise and fall in DNA damage biomarkers from just a single procedure. And so this is really evidence that even a single procedure, and the radiation doses in the procedures in the study, very similar to what we typically would get doing a manual PCI, but these can result in evidence of DNA damage. So I think, again, very provocative findings. And the other thing as it relates to occupational radiation safety in the Cath Lab is, not only are procedures becoming more complex as time goes on, but our patients, unfortunately, are getting more and more obese. And these are data that we published in 2019 in Circ Interventions showing that as patient BMI increases, going from left to right in the figure on the left, that you see this stepwise increase in the patient radiation dose, which makes sense. Bigger patients, you have to supply more radiation to generate the images. But what many may not recognize is that as patient BMI increases, as shown in the figure on the right, there's also a stepwise increase in physician radiation doses. And so the ongoing obesity epidemic, which really continues to grow, may be having an adverse impact on our radiation doses in the Cath Lab, and it's something we need to be thinking about how to decrease that risk to us. And I think robotics is a nice way to do that. And so these are data from the Pci study showing that for a manual PCI at the table, the average radiation dose was about 20 microgray in this study, whereas in the robotic cockpit, it was less than 1 microgray. And so this represented robotics being associated with a 95% reduction in physician radiation exposure. And just to put this into perspective, I like to show this kind of quick back of the envelope calculation. If we take two operators who both finish their fellowship at the same time, and operator A decides he or she is going to do all of their procedures manually, and operator B decides that they are going to do all of their procedures robotically throughout their career, and just for the sake of making this calculation simple, we'll plug in these radiation doses per procedure from the Pci study and just say that each of these operators is going to do 100 PCIs per year. You can see their annual exposures down at the bottom there, and then if we multiply this out over a 20-year career, you can see that with robotics, after 20 years in the Cath Lab of doing PCI, that the robotics operator actually has less radiation exposure after 20 years than operator A had in their first year of practice. And this is really where these decreases in radiation exposure per case can really be amplified over the course of one's career. And I think we need to be thinking more about the risk over our careers rather than just single cases. So the other thing that has come of interest of late is just the ability to potentially reduce risk during the COVID pandemic. And this was originally tweeted out by John George at Einstein in Philadelphia about the possibility of using robotics to decrease the physician's risk of contracting COVID by increasing the distance between the physician and the patient in these cases. And I think this is something that is very interesting and probably requires additional research, but I think an idea worth pursuing. So what are the potential patient benefits of robotic PCI? Well, one of the things that I think robotics is very helpful for is to measure lesion length. And so you can use the touchscreen buttons to actually measure the length of your lesion down to the fraction of a millimeter, and this seems to be an extremely accurate way to assess lesion length. These are data from Paul Campbell in 2015, where they compared visual estimates of lesion length to those obtained with direct measurements by the robotic system. And what they found were that the visual estimates were accurate only about a third of the time. A third of the time they were too long, and another third of the time they were too short. And this, of course, has implications on stent length selection. And in this study, they did suggest that using robotics would result in a significant decrease in the need for two-stent procedures by accurately measuring lesions. And then these are data from Aaron Becerra in 2015 as well, showing that compared to historical controls, the use of robotic PCI is associated with a reduction in longitudinal geographic miss. So again, important implications on measuring lesion length and not missing your lesion. So I think one of the most interesting things, which really was just published last month by Tejas Patel, was that robotic PCI seems to be associated with a reduction in patient radiation. And so in this study, they did a propensity score matched analysis of robotic PCI versus traditional manual PCI. And these were patients treated at the Apex Heart Institute between December of 2017 and March of 2019. All the PCIs in this were robotically were performed by two highly experienced operators. And interestingly, the data here include the initial robotics learning curve at this center. And what you can see in this propensity matched analysis was that patient radiation doses, both measured by air kerma and by the dose area product, were about 20% lower in the robotic arm. And so again, this was the first evidence that robotic PCI may be associated with a reduction in patient radiation doses. And so I think, again, very, very interesting results. And the authors provided two potential mechanisms by which robotics may reduce patient radiation exposure. One was by improved visualization. And so I think, as shown by this figure on the lower left of this slide, we've all done this when we're doing manual PCIs. The monitors are, of course, several feet away from us across the table, and we lean across the table to try to get a better view. And not only is this not good for our spinal health, but we're also putting our head closer to the source of scatter radiation. So this is a very unhealthy practice. Whereas in robotic PCI, you literally can put your nose up against the screen. And so the operators in Tejas' study suggested that the improved visualization with robotics may be leading to fewer cine-angiograms. They actually demonstrated that the number of cine-angiograms in the unmatched group was lower with robotic PCI. The other interesting thing that may have driven this reduction in patient radiation doses was table height. And so at this center, they have gotten into the habit of raising the table height during their robotics cases. And of course, when you're doing cases manually, there's a certain table height that is going to be comfortable. And when you go above that, it becomes, not great for operating at very, high table levels. Whereas when you're sitting in the cockpit, you can put the table as high as it goes, thereby reducing patient radiation dose, but yet having no impact on your ability to do the procedure. And so I think this is also something that requires additional study to show how we can optimally use this to reduce patient radiation doses during robotic PCI. So what are the studies that support robotic PCI in clinical use? So I mentioned the Pci study earlier. This was a prospective observational study, 20 physicians, 9 different sites, and 164 patients in this study underwent attempted robotic PCI. They had no device-related complications, and in this study they showed extremely high technical and procedural success rates. However, one of the limitations of this study is it was the majority of lesions in this were type A and type B lesions, and so definitely simpler robot or PCI procedures. This has been studied, however, in more complex PCI procedures. These are results from the Cora PCI study that Shami Mahmood did in 2017, showing that in a cohort of patients where the majority of lesions were type B2 or C, they were able to complete these procedures robotically, either with complete robotic, doing them completely robotically, or with partial manual assistance in over 90% of the procedures. They required manual conversion in only a little more than 7% of procedures. So again, really the first evidence that you can do complex PCIs using the robotic system. So this is something that particularly interests me about robotics is really the future of robotic PCI, and I think this lies in the potential for automation and the ability to do remote procedures. And so why would we want to explore automated robotic procedures? Well, one of the things to recognize is in the United States that the operator procedural volumes per year are relatively low. And so the average interventionalist in the United States only does roughly 50 PCIs per year. And you can see on this figure the number of interventionalists that do fewer than 50 PCIs per year is quite high. Well, with automation, you have the ability for the robotic system to actually provide low volume operators with high volume skills. And that is something that I think we should explore as a way to potentially make procedures safer. And I think the airline industry provides a very good example for the potential of this. The majority of flights around the world, commercial flights, it's only the takeoff and landing that are flown by the pilots. Everything in between is really flown by computers. And you see the quote in the middle there that it took us a while to admit it, but computers fly airplanes much more precisely than humans. And I wonder if the same could be true with PCI, that computers and robotics could do PCI more precisely than the average interventional operator. And that's something I think that we should explore as a way to potentially improve both the efficiency of procedures as well as the safety of procedures. And so one of the first automated maneuvers that became available on the robotic system, and this is something that's clinically available now, is called rotate on retract, or ROR. These were data that we put together back in 2017 and published in abstract form, showing that with using ROR and very experienced operators, there was a reduction in wiring time. compared to doing robotic procedures without the automated maneuvers. And so again, very, I think, helpful data showing that there might be benefits to using this on efficiently wiring vessels. Very excited to report that there'll be several additional automated wiring maneuvers that are going to become available later this year. These automated maneuvers, again, I think are going to be potentially, change the game as far as efficiency of wiring, particularly difficult lesions or getting into difficult side branches. And these two videos will show kind of the potential of automation. So you can see on the video on the left that this is a vessel that's being wired robotically, but without automated features. And as that video plays, you can see they have trouble getting the wire across that difficult bend in that vessel. And it just highlights that, I think in my experience, when you have difficulty crossing vessels robotically, often when you convert to a manual procedure, those lesions are the same ones that are difficult to wire manually. However, automation, when you watch the video on the right, you can see how efficiently using this spin technique, this automated spin maneuver, how efficiently that wire just slips down the vessel. And so again, I think that automation really has the ability to potentially improve our ability to wire vessels in a more efficient manner. So something I think that requires additional study. So looking at the evolution of robotic PCI, the original robotic systems were really intended to have the cockpit positioned in the corner of the room, as kind of shown on the image on the left. And in this scenario, the robotic controls and the robotic arm are hardwired to each other. This has evolved now where many hospital systems are placing the robotic controls in the Cath Lab control room. And so again, this is a hardwired connection, but does provide you the ability to eventually, not wear scrubs during these procedures, as shown on the second image from the left. On the third image from the left is something that there has been an interest in at multiple hospital systems around the world, which is having a central control room that is connected to multiple different cath labs within your hospital, so that you could potentially have a central operating station that controls multiple different robots in multiple different rooms. I think that's something that we will see evolve further in the future. And then all the way on the right, I think is something that we hope to develop further, which is really the ability to do robotic procedures remotely from one institution to another. And I think there are multiple different reasons why we'd want to pursue this. And so several problems that remote robotics could address. We know that emergent procedures, that time to treatment is critical. And when it comes to time to treatment, often that time is delayed because of the need to transfer patients from one institution to another. You could deploy remote robotics to overcome that. Access to expertise and treatment is geographically limited. So there are regions both in the United States and around the world where patients can't get to interventional operators. You could deploy robotics to overcome that issue. We have a shortage of skilled specialists. I'll talk a little bit more about that in a few minutes. And the incidence of STEMI and stroke are, of course, on the rise due to both the aging patient population as well as the obesity epidemic. And it's something that we could use remote robotics to address further. So what we're talking about here, again, with remote robotics is this idea of telestenting, where we have a physician in one location with the robotic controls. We have a patient in a separate location with the robotic arm. And over that geographic distance, you perform PCI. And, why do we want to develop this? Well, we have a lot of geographic barriers to PCI that still exist. These are data from 2012, so a little bit dated, but showing the areas of the United States where patients can get to a PCI-capable hospital within an hour. And so those dark spots on the map there show you where patients living in those regions can get to a PCI-capable center within an hour. And it's only about 80% of the U.S. population that can do that. When you go to more rural states like West Virginia, Alaska, and Wyoming, less than 50% of the population in those states can actually reach a PCI-capable hospital in under an hour, and that creates problems particularly with respect to STEMI care. And so remote robotics could potentially address this. We're also facing a shortage of interventional cardiologists in the U.S. These are data from MedAxiom showing that about 25% of the current interventional workforce are over the age of 60. So as these individuals retire in the next 5 to 10 years, we do anticipate there's going to be a shortage. And so again, you could use robotics to potentially overcome that shortage by disseminating interventional expertise. And then I think there is opportunity to do remote robotics in peripheral interventions. When we look in the United States regarding the rates of amputation for critical limb ischemia, you can see there's a lot of disparity as shown on the map on the left. And there are centers or geographic regions in the United States where the first approach to treating a patient with critical limb ischemia, unfortunately, is still amputation. And again, we could use remote robotics to reach those locations and at least make attempts at doing peripheral interventions. We know from the RAPID trial, as shown on the right, that it is both safe and feasible to do robotic peripheral interventions, particularly for stuff below the knee using the current generation system. And then I think an area that's very exciting is the potential to use robotics for remote stroke care. We now know that mechanical thrombectomy is associated with superior outcomes compared to thrombolytic therapy. And the issue that we have, though, in the United States is that we don't have enough comprehensive stroke centers. Of the more than 5,000 hospitals in the United States, less than 5% of them actually are comprehensive stroke centers capable of performing endovascular thrombectomy on a 24/7 basis. And so you could use remote robotics to disseminate the expertise of these stroke interventionalists to get to more centers, potentially reach more patients. So the studies that have looked at this, the first study to evaluate the ability to do remote was something that we published in 2017, this remote PCI study, where we simply asked the question, is it feasible for a physician to perform PCI from outside the procedure room housing the patient? And as shown on the left, the conventional configuration in the Cath Lab is, of course, to have the robotic controls in the same room as the patient with this hardwire connection. For this remote PCI study, we took the approach as shown on the right, which was simply to move the robotic controls down the hallway into an adjacent Cath Lab, close both doors, and then from that location, the physician had no direct line of audio or visual communication with the patient or the Cath Lab staff except using telecommunications devices. And so in this fashion, with the physician outside the procedure room housing the patient, we demonstrated that it was both technically and procedurally feasible to do these procedures. However, the limitation was that the robotic drive and the controls, as I showed, were hardwired in this study to each other. And so in order to be able to do remote procedures over much longer distances, we had to develop the ability for these the robotic arm and the robotic controls to connect to each other over an internet network. And that's something that we have been experimenting on in the last several years. These were data that we published in Neurointervention in 2019, where we developed both an ex vivo simulator model as well as an in vivo porcine model of remote telestenting, where in these we had a cardiology fellow and a scrub tech as the individuals in the room with either the simulated patient or with the live pigs. They obtained vascular access, they seated the guide catheter, they performed contrast injections, loaded all the devices on and off the robot, and performed the balloon inflations, but the rest of the PCIs were performed off-site by me. I was sitting miles away from the either simulated patient or the living pigs. And at the site where I was located, we have live fluoroscopy images piped in, we had live telecommunications brought in, as well as the hemodynamics and robotic controls. And so in these models, we had, we did them over miles ranging from about 4 miles up to about 103 miles. And interestingly, the stuff that we did over the very long distances was done over partially over just commercial internet. And so this culminated in procedures that we did where I was in Ludington, Michigan, which has a population of about 8,000. And the animal lab was in Grand Rapids, as shown on the map. And again, this distance was 103 driving miles. And over this distance, we showed that we were able to successfully do PCI procedures on these living pigs without any procedural complications. And so the next step of this was something that Tejas Patel did in 2018, published in 2019, where he performed telestenting on 5 humans in India in December 2018 over a distance of about 20 miles. All 5 cases were successful. There were no complications in any of these cases, so again, showing for the first time that this is feasible in humans. And so one of the questions that has come up is, what is the potential impact of network delays? You can imagine that if your internet signal was poor And what you were seeing as you were doing a robotics procedure was several milliseconds or seconds behind what was actually taking place in the cath lab with the patient. That delay or that latency would become problematic. And so we started asking questions about what is the latency or delay at which it becomes perceptible to the interventional operator. So these were data that we just published earlier this year, showing that as latency increases from left to right on the x-axis on the figure on the left, that you don't really see a perceived latency until you get up to about 400 milliseconds. And so this is really kind of the benchmark that we need to be thinking about as we further explore the ability to do remote PCI procedures, is that we should be looking to do these over networks that have latencies of less than 400 if our goal is for the operator to be able to do these without having to battle perceived latency. And we asked the question here just late last year, is geographic distance a barrier to telestenting? And so we set up 2 ex vivo models, and each of the models I was sitting in Boston at Robotic Controls. And in the first model, we did a regional model where the robotic arm was in New York City. And so over that distance of 206 miles, we demonstrated that we were able to do simulated PCI procedures without any problems whatsoever. And then we developed a transcontinental model where I, again, was sitting at Robotic Controls in Boston, and I was controlling a robotic arm in San Francisco. And over that distance, again, over 3,000 miles, we demonstrated that it is feasible to control a robotic system in a manner necessary to perform PCI, despite the fact that you're on opposite sides of the country. And so something that we definitely want to explore further. The other thing that was interesting about this is we studied the latencies in each of these models. And so we did these over both wired networks as well as 5G wireless networks. And in this, all the latencies in all of the models, regardless of whether these were done in the regional model or in the transcontinental model, regardless of whether the connections were hardwired, over a wired network or over a 5G wireless network, the latencies in this study were all under that 400 milliseconds. And so as I was controlling these procedures, I did not perceive any latency in any of the models that we studied. And I'm happy to report that this paper was actually just accepted for publication 2 days ago, so this will be available in the very near future. So I think there are some barriers that need to be considered as we continue to explore telestenting. This need for a second operator is something that is still an issue, and I still think we need to figure out, who that individual needs to be in these procedures. But they have to be able to obtain vascular access, perform angiography. I think engaging the guide catheter can be done now robotically, so I don't know that that's absolutely necessary for the person in the room to do that. Managing complications is a big deal, so that operator in the room needs to be able to manage complications. I still think there's opportunity for us to study how we could manage complications robotically from a remote distance. Network performance is still something else that we want to study. We're uncertain of the impact of network traffic on telestenting performance. The latency issue, I think we have good preliminary data that have given us some guidance on that. And then I think there are a whole bunch of interesting questions about licensure, credentialing, liability when you're doing this either across state lines or from one country to another, and these are other issues that need to be addressed. So I just wanted to finish with, I think Siemens really has a visionary approach to what the Cath Lab of the future looks like, and this really is going to be a combination of state-of-the-art image guidance that makes things that were formerly unseeable visible. And I think also that combined with robotics, the ability to do procedures very precisely, the addition of automation and the ability to do things remotely, I think really is going to transform, PCI procedures here over the next decade. And it's something that we're very excited to continue to work on. So just in summary, robotic PCI is associated with significant reductions in physician radiation dose and does not require the physician to wear lead. It's recently been shown that robotic PCI is associated with reductions in patient radiation doses. Automation in robotic PCI has the potential to standardize care, minimize human error, and potentially augment procedural safety. And then there's current geographic disparity to access to PCI as well as other endovascular procedures, and telestenting or remote robotics is being explored as a potential means to improve access to these procedures. And then I think there's potential to adapt telestenting technology to provide remote endovascular treatment of both stroke and peripheral arterial disease, particularly critical limb ischemia. Thank you.
Thank you very much, and I think Dr. Jack Buskey would agree. He's a co-chair on this session. This has been a wonderful exposition of this technology. And if he sort of permits, we can have a live case from United States and